Good evening, everyone, and welcome to the Lipid Lectures by Lipitas series, an academic initiative by Nexa Division of Intas Pharmaceuticals. The objective of Lipid Lecture series is to explore the evolving cardiometabolic insights with countries' leading experts in cardiology. In our today's episode, our distinguished speakers will address two critical dimensions of cardiovascular care: early intensive lipid lowering post ACS and the recent 2026 ACC AHA dyslipidemia guidelines. So with this, I welcome our faculty members. First, Dr. Rajiv Karnik, sir, who is the chairperson for our today's program. Dr. Rajiv Karnik is interventional cardiologist from Mumbai, and he is the former director, Heart Failure Clinic, Fortis Hospital, and teaching faculty at Asian Heart Institute, Mumbai. Dr. Karnik is having extensive 40 years of clinical experience. He's having professional memberships, including American Heart Association, American College of Cardiology, CSI, API, RSSDI, and he's also fellow of European Society of Cardiology and Society for Cardiovascular Angiography and Interventions. His areas of interest include interventional cardiology, heart failure, and preventive cardiology. Dr. Karnik has been awarded the Commonwealth Scholarship UK and served as a visiting clinician at Mayo Clinic, USA. He's graduated with 6 gold medals and topped the University of Bombay in all medical degree examinations. And Dr. Rajiv is also a recipient of prestigious Rashtriya Ratna Award in 2002. So welcome, sir.
Thank you. Thank you.
Our first speaker, actually, Dr. Shah will be joining us in some time. Dr. Shah is the head of Department of Cardiology and Director of Cath Lab Critical Asia Hospital, Mumbai, and he is also Director of Heart Rhythm Clinic, Mumbai. He is having 25 years of clinical experience. He holds numerous fellowships, including FSCC, FSCP, and is also Vice President of CSI Maharashtra and former Vice President, Indian College of Cardiology. His areas of interest include interventional cardiology, cardiac electrophysiology, complex PCI, and cardiac devices. Dr. Shah has performed more than 13,000 PCIs and 1,500 pacemaker ICD implantations. He is also author of 25 publications and recipient of Best Interventional Cardiologist of India Award in 2012. Our next speaker is Dr. S. Selvamani. Dr. Selvamani is Senior Consultant Interventional Cardiologist, Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. He is having 25 years of clinical experience and he holds professional memberships like FCGP, MCCP, and Fellow in Cardiology, MMM, Chennai. His areas of interest include interventional cardiology, coronary interventions, and clinical cardiology. And he is a recipient of the Vishishta Chikitsa Medal and a principal investigator in multiple national and international clinical trials since 2004 and regular faculty at national and national interventional cardiology conferences. So with this, I welcome all the faculty members, and now with this, I will hand over the session to our chairperson, Dr. Rajiv, sir. Over to you, sir.
Thank you. Thank you very much, Dr. Sandesh, for a very kind introduction. And you're quite excited to listen to Dr. Selvamani, because, dear friends, all of you will agree that IST, or atherosclerotic disease, the principal, the game changer has been the lipid management. And that is the cornerstone of treatment in the atherosclerotic disease, which can prevent the disease, which can prevent the progression, which can lead to regression of the atherosclerotic disease, and which reflects into the various hard endpoint reduction also. But to achieve this lipid reduction, there were different levels which were considered should be the bar. The bar should be, let us say, at 130, then 100, then 70. But then as the science and experience goes on advancing, we keep on getting newer information, and then the guidelines keep on changing. The bar level keeps on changing, to which we should, the goal to which we should reduce the LDL cholesterol. And we should always be abreast with, we should be always informed adequately about what is happening in the current scenario. And then this, the latest guidelines, that is 2026 guidelines, which is very pivotal, that which all of us should know, which will be covered by Dr. Silvamani, and he is an excellent speaker. And then I'm very sure that all the audience will be enlightened and with the latest knowledge about lipid lowering, especially the LDL reduction, and with this, the latest guidelines 2026 ACCHA, to which what we should do. And then it will be depending upon what the risk the patient is harboring, because it's not just, just near number that we are chasing. It is the depending upon the patient population which we are treating, what level of risk the patient is harboring, and accordingly we have to reduce the risk. And that will be very nicely elaborated by Dr. Silvamani. So I am also very eager to listen to Dr. Silvamani. Dr. Silvamani, please.
Yeah. Thank you so much, sir, for this topic, as well as I thank the organizers for calling me here. And it is whenever you give a talk,
Yes,
it only not only the listener, even when we prepare for the talk, we learn a lot of new things. In our busy practice, many times we may not be aware of so many new developments, and probably it is a very important thing that we should know about lipids. Not only that, although we do so much of intervention cardiology work, we do so many primary angioplasties, so many procedures, but the baseline for all those things is medical management. And whatever we are achieving today by doing
Doctor,
intervention.
sorry,
Yeah.
yeah, fine.
Can you
I
hear
just
me,
wanted
sir?
to say, no, I just wanted to say, can we go on full screen? Yeah, you have already
Yes,
done that.
yes,
Thank
yes,
you.
yes, yes. So, whatever we do, it is predominantly the medical management which is taking care of all our patients. And basically, our primary aim should be to prevent MIs, and then probably prevent atherosclerotic disease. That is why our targets, and then how we'll approach each patient is important. So basically, guidelines says two things. One is primary prevention. Primary prevention is in patients who do not have coronary artery disease. How to prevent this is very, very important. So if you do it properly, you can definitely prevent a lot of MIs in such type of patients. And of course, for patients who have already have coronary artery disease, what we call it as secondary prevention, in such patients, uh, definitely it is important to avoid recurrence of events. So we will see what the present guidelines says. So coming to this 2026 update, which is very, very important, there are certain important changes which has occurred. And what is it is predominantly what we should look into this is previously we were having something like 1 second, ride video panel. No, 1 second, let me just transcript studio. Good. So previously what we were doing is we had a risk calculation score which is predominantly based on what we used to call as pooled coherent equations, like Framingham and all those scores were there. Those were all pooled coherent equations. But today we have something called prevent equation. So this American Heart Association has come out with this prevent.
Sorry to interrupt, sir, but your voice is very low, sir. I mean, uh,
Is it?
yeah,
Uh, how is it now?
is it? Uh, yeah, that is better, sir. Now,
Is
but
it better? I am actually talking on this headphone only. In
right,
spite of
sir.
that, is it still low?
Yeah, take
Can
team,
can can the tech team increase the volume?
take team. Can you help in that?
They are saying my
Yes, sir.
volume is very less. uh, what they have started is, we call it as a prevent equation. So it comes as a calculator. You can get it free online, and then it asks some questions like your age, demography, BMI, and then urea, creatinine clearance, that is GFR, and all those parameters are asked, and then it gives you the risk factor. So this we are adopting today, and then based on that you will have to say whether this patient is high risk, intermediate risk, or borderline risk. So this scoring is for patient who does not have coronary artery disease. If somebody has either an MI or he has peripheral vascular disease, in such patients this should not be used. They are already under high risk. If somebody has heart attack or have undergone CABG or stenting or peripheral vascular disease, stroke, all those type of patients come under high risk group. For them that category is different. For here we are talking about patients too in primary prevention who has not had this disease. In such patients we'll have to use this prevent equation, which you can get online. This calculation is very simple and it will give you the risk of this patient. So based on that, what this risk says is you will get either it's a high risk, that means the incidence of CAD or MI or stroke or heart failure will be more than 10%. So they come under high risk, intermediate risk, border risk, and low risk. If somebody is less than 3%, then probably they come under low risk. Why is it important is, based on these levels, it is advisable to bring down your LDL levels so that you prevent this atherosclerotic cardiovascular disease in this group of patients. So that is a very, very important thing. And apart from that, what they have done is you will have to personalize the discussion. So you will have to look into, apart from LDL or total cholesterol, today we have given importance to LPA, that is LP little a, which is a very important factor also. And then you reclassify the risk of the patient, and then you decide and how to treat this patient. And very important thing is they have given importance for coronary artery calcium. See, remember, this coronary artery calcium is useful in only primary prevention, that too in cases where they come under borderline or intermediate risk, where you really want to decide whether to give them statins or not. Coronary calcium scoring is not useful in high risk group or in patients in whom already they have coronary artery disease. So this you should be aware. You should not keep on doing CT for coronary calcium scoring. You will have to do it specifically limited to patients with borderline risk factor. When you use this prevent equation, then probably it is very useful tool to start your treatment for such type of patients. So basically this is a basic summary. I will just go through the very detailed thing is, today what they have said is, if the risk is more than 3% also, there is a very good benefit in patients, for the patients when you start them on statin. That is a very important thing. So you should become familiar with prevent calculator, which is available free on the online. Online you can easily get it, and within a minute or two you will get your risk score of your patients. Sometimes you can try it for on you so that you become familiar on that, and then you decide on your therapy. And now, apart from all those things, now whatever the lipid levels that we used to look into, that previous guidelines, we were initially targeting at least 50% drop in the LDL or reduction in LDL from the baseline. So that was the initial game. But today, in spite of that, you will have to reduce 50%, but still you will have to gain levels that target absolute goal levels are important. So for example, when somebody has a very high risk patient or patient who has undergone angioplasty or bypass surgery, in such patients LDL should be less than 55. Even if your 50% reduction from the baseline is achieved, that is not sufficient today. So that is what is today's new change that has occurred. And you can use dual target, that is more than 50% LDL reduction, and at the same time absolute goal levels should be reached. This is one. And of course non LDL, that non HDL cholesterol levels are another point, especially for Indians, because apart from LDL we tend to have high triglycerides and low HDL, so that also forms one risk factor. So we can combine non HDL cholesterol levels also in our routine practice. So what is the level of LDL that you should bring it to in different type of patients? Many times we see that patient says my cholesterol is normal. Saying my cholesterol is normal without any other thing there is no meaning at all, because for each risk factor, each patient, the target levels are totally different. So what we should do is, when you calculate the risk, if it is very high risk patient, we should bring it down with aggressive statin and other drug management, bring down the LDL to less than 55. And in probably high risk or probably moderate thing, like especially in a diabetic patient or who are having atherosclerotic vascular disease, for them the LDL should be less than 70. And of course for primary prevention, who does not have any other risk and risk score is very less, probably in such patients it should be less than 100. Basically any normal Indian, probably you should have an LDL of less than 100. That is what is the primary goal that we are doing. And when you are looking at non-HDL goal, it is a difference of 30. So for the whatever goal we have for LDL, you add 30, you get the levels of non-HDL levels that you need to have in your practice. So add plus 30, it is the same thing that you are getting. So with this, next what we should look into is when to start this cholesterol. See, whenever I meet a pair, you look at even my PGs or my junior doctors who have just completed MBBS, and you ask them to get a lipid profile, should we do it at this age? That is, even a doctor who has completed MBBS, he says that I have not checked the lipid levels in my life. That should not be the practice today. So today the game is not over 40 or 50 or 60 or not after you get an heart attack. It starts at childhood itself. Probably you should screen everybody with lipid profile assessment even at the age of 9 to 11, and probably early detection even before the age of 19. You should check lipid levels once, and of course you should put them on lifestyle assessment, lifestyle modification, which is an early habit, so that you prevent this atherosclerotic vascular disease. And in familiar hypercholesterolemia, probably you will have to seek the treatment earlier. And of course in adult patients above 30 up to 70 or 90, so 30 to 59, you can use this risk calculator, which is online, which I already told you. And why is it important is the cumulative effect of high LDL levels. The more number of years your LDL is high chances that you will develop atherosclerotic disease. It could be heart attack, it could be stroke, it could be peripheral vascular disease, anything. So the duration of high LDL is very, very important. So you start your therapy very early. And of course, basically you apply this, and in younger patients like between 19 to 29, you will have to screen it at least once in 5 years to establish whether he has dyslipidemia or not. So this is a general guideline that we have. You start it early rather than waiting for be above 40 or once you develop a problem. So it is better you start screening accordingly in this earlier way. And apart from LDL, today lipoprotein A, lipoprotein small a, has also lot of atherosclerotic atherogenic properties. So that level is also very, very important. So if the levels are high, probably you have an high risk for this. So today what is the recommendation is, everybody should undergo LPA level assessment at least once in a lifetime. That is, you need not keep on measuring every time, but at least once you test. And if it is high, probably you should concentrate on that. What does it signify is, if the LPA levels are higher the risk for atherosclerotic cardiovascular disease. For example, if it is 125, you have 1.4 fold higher than the control group. If it is more than 430, you have 4 times the risk of developing heart failure as well as atherosclerotic cardiovascular disease. So basically, if LPA is also elevated, you should start them on statin to bring down LDL level. There is no doubt in that. That is a first important drug. And PCSK9 can be added because there is some mild to moderate reduction in LPA levels when you start them on PCSK9, especially inclisiran and other molecules which has a preventive effect. So this has also come into the guidelines today. And other important new thing that all of us should remember is apolipoprotein B, which we were not testing previously, is an important molecule. And measurement of this testing is also recommended in the guidelines. So what is ApoB is, see, normally what happens, this LDL is contained in cholesterol. So for some reason we are just measuring the rough levels of LDL or cholesterol mass that we measure today. That may not represent the exact LDL levels in our body in some conditions. Like for example, if the cholesterol mass becomes lesser, probably this can be a misleading calculation. But ApoB means what happens is, in each particle it has one atherogenic particle. So each particle contains one atherogenic particle. So when you measure this, you will get the exact levels and it can indicate the risk of atherosclerotic cardiovascular disease. So this is one new addition. Probably we'll have to add it in our armamentarium, but I will tell you when to test this. Should we test this in all patients? That is not needed. We will just tell you when to add this. So intensification of therapy is very, very one, and probably this helps you in achieving this recommended cholesterol levels, especially in high risk groups, especially this cardio-renal syndrome, diabetes, elevated TCL, and patients with established atherosclerotic cardiovascular diseases. And these are the guidelines that we have in most of the patients. As I already told you, in high risk group, LDL should be less than 55, and in high risk patients with diabetes, it should be less than 70. And if somebody has atherosclerosis, probably when you do a carotid scan or a peripheral vascular disease, if there is any atherosclerosis detected in them, LDL should be less than 70. So basically this is what we are trying to achieve. And if you are measuring ApoB, it gives you the exact value. Sometimes plain LDL calculation may not be correct. So what the guideline says is, you measure ApoB if you have reached this LDL recommended levels. For example, if you have reached 55 in a patient and still you want to know the residual risk, you look at ApoB. ApoB, if it is normal, then the risk is less. If the ApoB is high and LDL is low, still you tend to have high risk for a cardiac attack or atherosclerotic cardiovascular disease. That is what is the main thing that we see here in this guideline. So very important thing is, you remember this CPR framework. That is, you will have to calculate 10-year risk in patients for primary prevention. This is for who do not have atherosclerosis or who do not have any other major coronary artery disease or stroke, and calculate 10-year risk, and then you personalize with risk enhancer. Probably you look into strong family history, and then probably you can look into urine albuminurias. You personalize that to each patient, and then you can reclassify. If everything is still borderline, you can reclassify using coronary calcium score, CT scoring of things only in this borderline or intermediate group of patients. Sometime you can look into HSCRP also, high sensitive CRP levels also, to decide whether to start them on statin or not in borderline patients. So this is the actionable guidelines that they have set. And if somebody has a very high risk, don't worry, you will have to definitely give. Intermediate risk also, you should start them on statins. Probably low risk and then borderline risk. It is ideal to start a lipid lowering therapy in borderline also, but very low risk, when the risk is less than 3, probably we can consider. There you can make use of this coronary calcium scoring as well as high sensitive CRP levels, and then decide whether you will have to start them on statin or not, and what should be the goal for that patient. So basically, for most of us, a normal person, LDL should be less than 100. So that is the guideline that which is suggesting today. So in this, calculate and then personalize and recalcify. This is what CPR, that if you remember, if you do that, it is going to do a lot of benefit for your patients here. So here now you calculate, as I told you, if the risk is more than 10, start them on statin. Even 3 to 5, start them on statin. Less than 3, probably you do this calcium scoring. In calcium scoring, what you see is, if the calcium score is 0, then it is safe to defer statin therapy for such patients. If the calcium score even 1, probably your recommended LDL level should be less than 100. If the calcium score is high, probably more than 1000 means it's high risk. Probably the LDL level should be less than 55. So these are the recommendations with the calcium scoring, where you will have to put them on strong statins so that you can decide on your statin dose and bring the lipid levels to that recommended levels. And there are some groups of patients, even without looking at the risk factors, you will have to start them on statin, what you call it as automatic statin candidates. So any patient above 40 who is a diabetic, irrespective, probably you will have to have the LDL levels to less than 70, and most of them should be receiving statin there. So it's an automatic recommendation. Any patient with chronic kidney disease, definitely you should start them on statins. Any stage 3 kidney disease, you start them on LTT, and any patients with HIV. So basic is, all these patients have high atherogenic property. So to bring it down, so irrespective or whatever it is, they become automatic statin candidates. So today with this CPR, we are at a new standard of care, and we want to again re-emphasize on you, calculate in patients for primary prevention, whether low, borderline, intermediate, and decide on the levels of LDL that what you need to have, and then your target for high risk group is less than 55, and at least moderate or intermediate high risk groups, it should be around less than 70. So this universal thing you just remember, and at least once in lifetime check lipoprotein A, and then you decide on your therapy. And once you reach the target, you can check ApoB to make that, does he still have added risk, and then you can try to bring down the lipid levels very low. So previously in 2018, we were calling it as guideline for management of blood cholesterol. Today it has become as guideline for management of dyslipidemia. So this is the change which they have done there. And of course measurements, how to measure, has also been recommended in different group of patients, which I have already roughly told you. Even at the age of 9 to 11, you will have to measure this level. And ApoB and lipoprotein small a, also I have already told you, lipoprotein A small a is once in lifetime you check and then decide. ApoB, when you have reached the target LDL levels, To look into the residual risk, you can look into ApoB. I already told you why ApoB is more precise than LDL. So these are some of the ways how to prevent. And already we have the risk score. This is the same thing which they have put it in the column, and then they have advised. And this is again to re-emphasize in 2026 the same thing which I told you, lipoprotein A and risk involved with that. And coming to atorvastatin versus rosuvastatin. See, oral statins are primary drug for dyslipidemia. It is a first line therapy to bring down atherosclerotic cardiovascular disease. I get a lot of patients seeing something on the WhatsApp. They say cholesterol is not important, your cholesterol should be high. Don't give importance to all those things. That's all, they don't have any evidence. They just spread it on Insta, WhatsApp, which is probably, I don't know why they do that, but advise all your patients, and you take care of yourself also. Lipid levels are very, very important, and statins are the first line of drug. And we have extensive CVOT evidence to demonstrate statin is very, very useful as well as in primary as well as secondary prevention. And atorvastatin and rosuvastatin can achieve LDL reductions depending on the dose that you are giving, which we will just go through that. And when you are expecting high intensity statin, or when you want to bring down the LDL levels to more than 50% from the baseline, so what is the dose recommended is you should give at least 20 to 40 milligrams of rosuva and at least 40 to 80 milligrams of atorvastatin. We call it as high intensity statin, where your LDL comes down to more than 50% from the baseline. And moderate intensity is 5 to 10 mg, 10 mg to 20 mg of atorvastatin and 5 to 10 mg of rosuvastatin. And low intensity is very low, which we don't practice at all nowadays. So either high intensity or moderate. For most of our cardiac patients, it is high intensity. That is what we practice in our today's practice. And especially in patients with kidney disease, there is a concern that should we give rosuvastatin or atorvastatin. Most of the rosuvastatin is excreted by kidney. So if somebody has a GFR less than 30, probably some dose reduction in the dose of rosuvastatin is needed, because you might have some accumulation of this drug. But generally, most of our nephrologists prefer atorvastatin in patients with renal failure. But rosuvastatin also can be given, but you will have to reduce the dose for that. So this is the guideline recommendation. And in heart failure also, rosuvastatin and statins have shown that it reduces risk of hospitalization, and other overall mortality also is reduced with statin. So to summarize, what this dyslipidemia guidelines substantially, it expands statin therapy eligibility for many patients compared to 2018 guidelines. So when you look at the population and when you look at the indication, it is almost 54% of patients in the population will be eligible for lipid lowering therapy. So it is become a very, very important molecule to bring down your cholesterol and prevent atherosclerotic cardiovascular disease. This is the summarization. And in some patients like diabetes or whoever it is, if they are unable to tolerate statin, it is reasonable class 1 evidence to start them on ezetimibe or bempedoic acid or PCSK9 to bring down the risk of ASVD. And today it is a systematic approach of LDL reduction that is very, very important, along with lifestyle management, use of maximum tolerated dose, and then probably you go ahead like this. And this is what the guidelines have shown. Treat earlier, lower lifetime risk, universal and earlier lipid screening. Screen it for almost everybody. Right from the age of 9 years you can start. Early pharmacotherapy in selected groups of patients to prevent ASVD. Lower LDL is better in long term, so that is also a very important thing. And then introduction of prevent calculator, which is very, very clear, available online at free of cost. And coronary calcium scoring, LPA levels and apolipoprotein B, which we have already discussed. And today, combination therapy is very, very important to bring down to the level of whatever the recommendation is. You may not achieve only with statin. Statin is primary, very important, you should give. Along with that, if you are not reaching the target, you can combine it with ezetimibe, bempedoic acid, PCSK9 inhibitors, including inclisiran, are recommended. So, in my practice, most of the patients reach the target when you combine statin and ezetimibe and bempedoic acid. Many patients with only statin and ezetimibe, but most of them they require bempedoic and ezetimibe combination along with statin. Very few patients they require PCSK9 today when you combine these molecules as a oral molecule. And of course, high risk group, it is strongly recommended you bring it down to less than 55. Even in elderly patients, it is useful. Even over 75, you can look into the other risk factors and then look into that. In Indian perspective, it is very, very important because we have atherosclerotic disease 10 years earlier, and cumulative risk is very high. Lifestyle is not sufficient. You need to put them on medicines, and probably you should look for lifetime risk reduction in most of our patients. Here, lipid levels for all of us probably it should be less than 100, and again less than 55 for a very high risk group. In certain group of patients where intermediate or borderline risk, as I said, you can make use of this calcium score. And in patients who have reached target, you can still check ApoB levels to look into the residual risk factors. And this is again the re-emphasize whatever I have told you. And you remember all these important changes and you put it in your practice. Definitely it will be a great service to the society, preventing a lot of ASVD and problems with stroke and acute MI and other peripheral vascular disease. Thank you so much for the silent listening.
Thank you. Thank you. Am I audible?
Yeah, you are audible, sir.
Yeah, okay. Great, Dr. Sethuraman Silvamani. It was a very, very nice coverage of this latest guideline, 2026 guidelines. Dear friends, all of you will agree that, this LDL target, what is as of today, and especially in the different risk groups by which can be personalized, which can be calculated by risk calculator. It is very important. And then especially this prevent calculator, I think all cardiologists and even all physicians should also have, because this is number one, it is free of cost. Number two, it is done with extremely huge number of subjects involved. Like almost 3.3 million people were involved in derivation stage. And again, for just the validation, another 3.3 million people were involved. Then the risk which is predicted and which is actually observed, there is almost a slope of 1:1. If the prediction is 30, then this thing, even the observed value is also 30. So that is called as the risk prediction value, which is as opposed to that with pooled cohort equation, it was almost 50, just the 50%. So this is one of the most accurate one. It has also involved additional things like calcium scoring, ApoB, lipoprotein A, etc. And if you remember this Inase, when he used to come for Indo-American summits, he always used to insist on the looking at the deadly lipid tetrad in the Indians. And in this deadly lipid tetrad, he always used to include this lipoprotein A and ApoB, etc. So which has again come back in American general global guidelines also. So I think we should, all of us should be very acquainted with this particular prevent calculator. And as Dr. Selvamani has said, that even the risk as low as 3% starts having increasing the event rate. Unlike pooled cohort in which we used to give that 20, more than 20 as high risk. So here, very small risk also with this risk enhancers we can actually involve in our active high intensity and moderate intensity statin. So I think that was a very nice disposition by Dr. Sethuraman. And what we will be doing is we will be taking question answer because the other lecture is also on lipid only. the early lipid treatment in acute coronary syndrome. So if Dr. Selvamani, if you agree on that, then we'll have this question answers or at the end of after Dr. Chetan.
Yeah, definitely,
Yeah,
definitely. Let Dr.
yeah,
Chetan Shah
yeah,
finish
okay.
his talk, and then we'll
Yeah.
have the discussion, sir.
Yeah, okay. And Dr. Chetan is also Dr. Chetan Shah. His introduction is already done by Dr. Varukar earlier. So he is discussing another very, very important topic, and that is early initiation of lipid therapy. That is number one. That too in combination lipid therapy, and how much impact it is going to make not only on the lipid level, not only on this number of people where we can achieve this target which Dr. Selvamani has given as on today, and its impact on the various event rate. So these three things he will be covering very nicely. Because if you are doing it for heart failure, if you are doing it for hypertension, where we are yeah, if you're doing it for hypertension, if you're doing it for heart failure, then why not for acute coronary syndrome? We always give the dual antiplatelet. We don't say that we'll give one, and if it fails, then we'll give the second one. So why not for doing preventing another rate? We should give a combination treatment and that at the earliest. So that is what Dr. Chetan Shah will be discussing with all of us. So Dr. Chetan Shah, I know you are going to cover it excellently. So the stage is yours.
Thank you, Raju bhai. Good evening, everybody. Can you hear me?
Yes, yes, very well.
Yeah, and screen is okay, sir.
Right now, we are seeing only your face. So your presentation screen is not there on the line.
Sir, please share screen.
Okay, let me see. Is it shared
Uh, yes, but it is still not full screen presentation.
now?
Yeah, no,
Okay,
that is.
okay. Thank you. Good evening, everybody. So, as Dr. Karnik has said, that we'll be talking on a very important topic of
Sir, sorry to interrupt. Your slide is not visible, sir.
Kindly switch on, go back to your share screen, share it again.
share it again.
Yes, sir. It is not you. We are seeing only you.
Can you see it now?
Yes, we can see. Make it full screen. No, no, no. Again, you went off. Went back. Just go to that. It was there.
So it's
Share
not.
screen.
When I make it full screen, it goes away.
No.
Yeah, yeah, perfectly fine.
Yeah. Okay. So, good evening, everybody. Again, we'll be talking on a very important topic of early intensive lipid lowering therapy post ACS, about the timings, targets, and the outcomes. So, the right time, the right target, and the right impact. Looking at the global burden of residual risk after ACS, it's extremely high, persistently high risk. Long-term follow-up studies show a 5-year mortality rate of roughly 20%, with the highest risk of recurrence occurring immediately after discharge. So how immediately? So we'll see in subsequent slide that there is a maximum incidence in the first 90 days. The recurrent rates in stable post-ACS patient, long-term annual rates of recurrent events range from about 4.4 to 6.7%. In low and middle income countries, the burden is high due to earlier onset of ACS and shorter survival times compared to high income countries. Why timing is important? So, as I've said earlier, patients with ACS remain at extremely high risk for recurrent major adverse cardiac events, with studies reporting that about 15 to 35% of patients experience a major adverse cardiac event within the first year. Extremely high early risk, that is nearly half of all the recurrent major adverse cardiac events in the first year occur within the first 90 days, post discharge. So, if we look at the concept of high risk plaque and the patient, so which are the high risk plaque in the patients? So, the patients with rupture prone plaque, that is thin cape fibroadenoma, which will result in plaque rupture, erosion prone plaque, which will result in plaque erosion, and eruption prone calcified nodule, which will result in eruptive calcified nodule, which are responsible for the events in acute coronary syndrome and sudden cardiac death. Uh, why timing matter in lipid lowering? So the clinical event curves from major acute coronary syndrome trials separate early, suggesting that intensive lipid lowering therapy confers a meaningful benefit within days to weeks after initiation of therapy. So that timing is very important. As early as possible, so immediately after the acute coronary syndrome. In Miracle trial, the atorvastatin 80 milligram initiated within 24 to 96 hours after the ACS reduced the recurrent ischemic events by approximately 16% at 16 weeks. Rapid LDL cholesterol reduction improves the endothelial nitric oxide bioavailability, decreases the vascular oxidative stress, and enhances the coronary vasomotor function within days. So that's again very important point. Early therapy attenuates the inflammatory activation reflected by reduction in hsCRP and inflammatory cytokine, thereby contributing to plaque stabilization. Again, an important factor in preventing the recurrent event. And delayed treatment initiation often results in therapeutic inertia, lower long-term adherence, and failure to achieve recommended LDL cholesterol threshold during the highest risk period, that is post-ACS, immediate post-ACS. So if you look at the historical evaluation of ACS lipid management, to start with, earlier lipid management paradigm focused on primarily on moderate LDL cholesterol reduction initiated after hospital discharge and often delaying the aggressive therapy during the highest risk period. Then comes the Prove It TME22 trial, which fundamentally shifted the practice by demonstrating superiority of intensive atorvastatin therapy over standard pravastatin therapy after ACS. Then we have improved a trial that established that adding ezetimibe to statin therapy further reduce the cardiovascular events beyond statin monotherapy. And then we have studies with PCSK9 inhibitors, including the Fourier and the Odyssey outcome, demonstrated that achieving LDL cholesterol level near 30 was both effective and safe. That again is an important point in the management of lipid post ACS lipid management. And the current treatment philosophy is based on the principle of lower, earlier, and longer, emphasizing a rapid achievement and sustained maintenance of very low LDL cholesterol levels. So this was one of the 2025 current cardiology reports about the combination of lipid lowering therapy after ACS by Julia Brands. Should this be the new standard of care? And what it summarizes that early combination therapy represents a pragmatic strategy to accelerate the LDL cholesterol goal achievement after acute coronary syndrome. While this approach could narrow current treatment gaps, it must be balanced against the trend towards the personalized risk-based lipid management. So this is what this latest report says. Early combination therapy post ACS So if we look at the guidelines post ACS, ACC, high intensity statin for all ACS patients, that is atorvastatin 40 to 80 and rosuvastatin 20 to 40. That is class 1A indication, and then concurrent ezetimibe is class 2B indication. ESC guideline again, high intensity statin as early as possible, class 1C indication, and concurrent ezetimibe is class 2A indications. On maximally tolerated statin, if LDL cholesterol level less than 55, continue therapy. If the LDL cholesterol level is more than 70, add non-statin drug like ezetimibe or PCSK9 inhibitor, inclisiran, bempedoic acid, again class 1 indication. If LDL cholesterol is between 55 to 69, addition of non-statin drug like ezetimibe, PCSK9, inclisiran or bempedoic acid is reasonable, again class 2A indication. So these are the guidelines for combination therapy post ACS. If you look at 2026 ACHA guidelines about the risk, very high risk ASCVD, the goal should be LDL cholesterol less than 55. I think this has already been discussed. Therapy should be high intensity statin. In addition to that, we can add ezetimibe or PCSK9 inhibitor. In secondary prevention, the goal is less than 70. First line therapy is high intensity statin and ezetimibe. For primary prevention, high risk patients, the goal is less than 70 milligram percent high intensity statin, and to achieve the goal, we can add ezetimibe or PCSK9 inhibitor. Primary prevention, intermediate risk less than, so LDL cholesterol should be less than 100 milligram percent, and the therapy should be moderate intensity statin. And we can have calcium scoring to guide the therapy decision. And in severe hypercholesterolemia, the goal again is less than 100, and statin plus ezetimibe or PCSK9 inhibitor should be the line of treatment. So the LDL cholesterol gap and the clinical inertia. So despite potent statin, the real world data reveal a massive gap between the guideline goals and the clinical attainment. The Da Vinci study showed that only 18% of very high risk individuals achieve LDL cholesterol of less than 55 milligram percent. The Santorini registry confirmed that 68% of the European patients fail to reach the risk-based goals, primarily due to lipid lowering therapy underutilization. In the US-based GOLD registry, 2/3 of patients on maximally tolerated statin still had an elevated LDL cholesterol levels. The clinical inertia, the failure to intensify therapy when indicated, results in more than 80% of patients remaining off target at 2 years. This persistent residual risk mandates a shift from a stepwise model to upfront high intensity combination of lipid lowering therapy. So if we go to the high intensity statin, the foundation therapy, the high intensity statin including atorvastatin 40 to 80 and rosuvastatin 20 to 40 remain the foundation of post ACS lipid management worldwide. These regimes typically reduce LDL cholesterol by about 50 to 60% with additional pleiotropic, anti-inflammatory and endothelial stabilizing effects. Statins also reduce hsCRP levels independently of lipid lowering therapy, supporting an anti-inflammatory contribution to the cardiovascular risk reduction. Meta-analysis from cholesterol treatment trialist collaboration demonstrated that every 38.7 milligram LDL cholesterol reduction lowers a major cardiovascular event by approximately 22%. And early in-hospital initiation significantly improves the long-term adherence rates compared with delayed outpatient initiation strategies. So let's go through some trials. This was a miracle trial which had more than 3,000 patients of unstable angina, non-escalation MI, randomized to atorvastatin 80 milligram versus placebo within 24 to 96 hours post ACS. There were significant reductions, particularly in recurrent symptomatic ischemia requiring urgent hospitalization. Miracle also established the safety and efficacy of initiating high-intensity statin therapy during the acute unstable phase of acute coronary syndrome. Intensive atorvastatin therapy reduced the composite endpoint of death, myocardial infarction, cardiac arrest, and recurrent ischemia. requiring hospitalization by approximately 16%. And the LDL cholesterol came down from 124 at the baseline to 72 in the atorvastatin arm. This is another landmark study, that is PROVE-IT TIMI-22 study. Again, what it did was, these were all the patients with acute coronary syndrome which were randomized to a routine therapy of pravastatin 40 milligram versus intensive therapy of atorvastatin 80 milligram. And if you look at the composite triple endpoint of death, myocardial rehospitalization, atorvastatin was much better than pravastatin. The composite endpoint occurred in 15.7% of patients assigned to atorvastatin and 20% of patients assigned to pravastatin, reflecting a hazard risk reduction of about 24%. A2Z trial, A2Z evaluated in early intensive simvastatin therapy versus delayed conservative statin therapy after ACS. And this arm separated after some time. This primary endpoint reduction did not reach statistical significance initially, but later follow-up demonstrated a favorable trend towards reduced cardiovascular events. This was one of our own study, Rozovis 1 and Rozovis 2 study. Rozovis 1 was published in Indian Journal of Indian College of Cardiology. This was in about 219 Indian patients, just to know how well they were tolerated, and they were very well tolerated. Indian patients hypercholesterolemia, and 10 and 20 are more effective than 5 milligram in high cardiovascular risk patients. So as we see in this slide, that rosuvastatin 10 and 20 were significantly significantly important in getting the LDL cholesterol down. This was what is applicable to the context of today's talk, that is the Rozovis 2 study. This was published in Indian Heart Journal. Again, our own study, efficacy and safety of the intensive dose of rosuvastatin 40 milligram per day in patients with acute coronary syndrome and high risk of cardiovascular disease. We had about 162 patients with acute coronary syndrome, and the results of the study showed that 40 milligram rosuvastatin initiated early and continued for 12 weeks was effective in terms of reducing LDL cholesterol and very well tolerated. If we look at the reduction, there was significant reduction in LDL cholesterol, total cholesterol, triglycerides, non-HDL cholesterol. And if you look at the safety on the right hand side, there was no significant elevation of CPK, SGOT, SGPT, serum creatinine levels, which we did at the baseline, week 6 and week 12. No difference in EGFR. So I think they were very well tolerated in our Indian patients, 40 milligram of rosuvastatin. Talking about the residual risk despite statin. So despite high intensity statin therapy, a substantial proportion of acute coronary syndrome patients continue to experience the recurrent ischemic events due to a persistent residual risk. Approximately 40 to 50% of very high risk patients fail to achieve LDL cholesterol levels below 55 milligram percent with statin monotherapy alone. So I think this is extremely important in combination therapy after acute coronary syndrome. So what do we have? What do we have in our armamentarium in addition to this high intensity statin? So we have ezetimibe. How does ezetimibe act, and what is the mechanism and the rationale? So ezetimibe selectively inhibits the intestinal cholesterol absorption through blockade of NPCL1L1 transporter in enterocytes. When combined with statin therapy, ezetimibe produces an additional 20 to 25% reduction in LDL cholesterol level beyond statin monotherapy. Combination therapy enhances the LDL receptor upregulation while minimizing compensatory cholesterol absorption mechanisms, and ezetimibe demonstrates an excellent tolerability and safety profile with a minimum risk of hepatic or muscular adverse events, and the simplicity of once daily dose administration supports the broad implementation in post-ACS patients secondary prevention strategies. So, what do we have here? We have plaque stabilizing effects of statin and ezetimibe, both. If we talk about the Indian landscape, we are ethnically heightened risk group. Indian patient often presents with ACS at a younger age with aggressive multivessel coronary artery disease. The Lipid Association of India emphasizes that South Asians have a ethnically unique aggressive lipid profile. LAI 2023-2024 updates recommend the most stringent LDL cholesterol targets globally, less than 50 milligram per cent as rapidly as possible in patients with acute coronary syndrome. They specifically advocates for the upfront addition of ezetimibe to high intensity statin upon the hospital admissions. Oral combination therapy emphasizes as a pragmatic and cost effective standard for India's resource limited strategy. So, affordability is a problem. Otherwise, we can use PCSK9 inhibitors. But I think this is a relatively cost effective option, that is high intensity statin and ezetimibe together, as against use of PCSK9 inhibitors. And this approach preempts the harm of delay in population where the baseline risk is fundamentally higher. So this is the OLA study optimizing LDL cholesterol after acute coronary syndrome, and this was again rosuvastatin 40 milligram plus ezetimibe 10 milligram. And in this prospective study, a combination therapy achieved a 62.3 mean LDL cholesterol reduction as compared to 45% with the monotherapy. And the mean LDL cholesterol dropped from 115 to 43 by week 4 in the combination arms, and the results were consistent across STEMI and diabetic subgroups, supporting a broad applicability. The study demonstrated that the simultaneous oral therapy achieves target that high intensity statin monotherapy cannot, and the absolute difference in LDL cholesterol lowering was 21.9 milligram per cent in the favor of upfront combination. So again, an important study as far as our Indian population is concerned. This was LAI early ACS. This was a randomized trial comparing atorvastatin 80 plus ezetimibe to atorvastatin 80 alone. And again, at 4 weeks, less than 70 milligram per cent achieved in 55.6% of combo group versus about 29% in the monotherapy group. And at 12 weeks, the differences widened significantly. About 96% achieved less than 70 milligram per cent in the combo group as against 58.8 in the monotherapy alone. This was a SWEDART study. What it did was early combination therapy significantly lowered the risk of major adverse cardiac events compared to no ezetimibe. And if you look at the 1 year major adverse cardiac event incidences, 1.79 per 100 patients versus 4.03 in no ezetimibe group. Late initiation associated with higher MACE risk at 1 and 2 years compared to the early use. So again, this is extremely important to use upfront combination therapy in this acute coronary post-ACS patients. This was a racing trial, moderate statin combo versus high intensity statin. So this was moderate intensity statin plus ezetimibe versus high intensity statin, and the combination therapy achieved LDL cholesterol less than 70 milligram per cent significantly more often at 1, 2 and 3 years, 73% versus 55. And the combination group had lower rates of drug discontinuation or dose reduction. And the primary composite endpoint was non-inferior to high intensity monotherapy. So this suggests that the moderate statin doses plus ezetimibe can provide a superior efficacy with potentially better long-term tolerability. And it challenges the concept of ezetimibe as the only add-on and supports its use as an upfront therapy. Now coming to the improve it. Ezetimibe added to statin after acute coronary syndrome, and the conclusion of this study was added to statin ezetimibe can improve cardiovascular outcomes while reducing the LDL cholesterol levels below the current standards. So there are difference in the mechanism. We have statins which will lower the intracellular cholesterol levels. We have ezetimibe, decreased intestinal cholesterol uptake, and we have PCSK9 inhibitors, decreased LDL receptor degradation. All of them will lead to LDL receptor upregulations and enhance LDL uptake and reduction in LDL cholesterol levels. Now let's look at a couple of trials with PCSK9 inhibitors. The 4-year study randomized more than 27,000 patients with established ASCVD to evolocumab versus placebo on a background of statin therapy, and the median achieved LDL cholesterol level reached approximately 30 milligram percent evolocumab arm. It reduced the risk of cardiovascular death, MI, stroke, and hospitalization for unstable angina or coronary revascularization by about 15%. The MI risk was reduced by about 27%, and the stroke risk was reduced by 21%. And there were no significant increase in the neurocognitive events, hemorrhagic strokes, or major safety concern despite the ultra low LDL cholesterol levels. Looking at the Odyssey trial, Odyssey outcome enrolled nearly 19,000 patients 1 to 12 months after acute coronary syndrome and randomized them to alirocumab versus placebo. And alirocumab achieved a substantial LDL cholesterol reduction with the median level approaching to about 40 milligram percent. And the primary composite endpoints of coronary death, MI, stroke, or unstable angina require hospitalization was reduced by about 15%. And patients with baseline LDL cholesterol level of more than 100 milligram percent derived the greatest absolute stroke reduction and mortality benefit. And the trial strongly reinforced that the concept that aggressive lipid lowering therapy after ACS improves the long-term cardiovascular survival. So LDL cholesterol level, how low we should go. So if you look at the ESC guidelines, they recommend LDL cholesterol level below 55 for all high-risk ACS patients, and consideration of LDL cholesterol level below 40 in recurrent events. So this is a proposed algorithm, proposed clinical algorithm post ACS, high intensity statin plus ezetimibe. If the patient has multivessel disease or if the LDL cholesterol is target is not achieved at PCSK9 inhibitor. Further, if still not achieved, then consider, or not affording, then we can consider bempedoic acid, and if affording, inclisiran. So what are we going to learn from this entire exercise of post ACS lipid intensive lipid management? The post ACS period represents the phase of greatest vulnerability for recurrent ischemic events and progressive plaque destabilization. And the intensive lipid lowering therapy should begin as early as possible, as benefits emerge within days to weeks after therapy initiation. Lower achieved LDL cholesterol level consistently correlate with reduced rates of myocardial infarction, stroke, revascularization, and cardiovascular death. And combination lipid lowering therapy is increasingly required to achieve contemporary LDL cholesterol goals in very high risk patients. And modern secondary prevention is now defined as a principle of lower, earlier, and longer. So earlier it was lower the better. Now it's lower, earlier, and longer using aggressive and sustained lipid LDL cholesterol reduction. So I thank you very much for the patient listening, and we'll be happy to share questions. Over to you, Raju bhai.
Thank you, Dr. Chetan Shah. It was a very, very good, in fact, discussion on early and intensive lipid lowering, and that too with a combination therapy. Dear friends, you all will agree that all the interventional cardiologists, they are well versed with giving dual antiplatelet loading dose. Right in the casualty, in the ER, we give loading dose, and then we continuously, without Failing, we continue with this dual antiplatelet till at least 3 months, 6 months, 1 year, depending upon the case. But that doesn't happen with lipid. Now, Miracle trial was the first trial which showed that we can get very early benefit. And subsequently, all those trials which Dr. Chetan Shah very nicely discussed, they had the good benefit. And how early can be the benefit? There is a very good report on lipid apheresis, LDL apheresis. And after doing just like dialysis, which is done by nephrologist, by LDL apheresis, the LDL is removed by this dialyzer, and the immediately post apheresis, the LDL comes down. And in that study, it was done that within just 3 days, not like 3 weeks or 1 month or 6 months or something. Within 3 days, when this PET CT was done with the plaque inflammatory background versus the plaque scatter, so within 3 days there was a benefit. So we can get the benefit as early as 3 days. And that is what I think Dr. Chetan Shah was harping on, that we should start early, hit hard, bring down the LDL to as low as possible, and continue the treatment. Unfortunately, that practice is not, imbibed in our entire uh, this thing, all the cardiologists in the country. But just like dual antiplatelet, we should go for combination therapy, and then especially the racing trial, which he showed, that was absolutely head to head. Because earlier trials, there were different molecules, pravastatin versus simvastatin, or low intensity versus high intensity. So here it was opposite. High intensity rosuvastatin versus moderate intensity rosuvastatin with ezetimibe. This was a very unusual presentation, because many of our patients, they are little reluctant to take high intensity statin because of muscle set, the WhatsApp reported various side effects, etc. So here I think with the moderate intensity statin with ezetimibe combination, he showed that racing trial which was published in JAHA 2023. Journal of American Heart Association. That is another thing that he had very nicely informed us. So I think with this, we had very excellent dual presentation. That one was Dr. Seturaman Selvamani on the latest guidelines 2026 of American Heart Association, especially with an emphasis on the latest incorporation of, for especially for Indian population, what we should do, like lipoprotein A, ApoB, and so on and so forth, using this prevent calculator, which is available easily, and then do the risk calculation, calculate, personalize, and reclassify. And after reclassification, go for the intensive statin and combination. And then especially in acute coronary syndrome, be very, very personal, start very early and start with the combination treatment. I think very important take home messages for all the cardiology community. So I think with this, my moderator's function is over, but the most important is still the lot of questions must be there. So Dr. Varudkar will probably will have in his this thing back, lot of questions which have come from different centers. So those will be presented to Dr. Salmani and Dr. Chetan Shah. So I'll take your leave, Dr. Sandesh now, and then the question answer can be done by Dr. Chetan Shah and Dr. Selvamani. Thank you very much indeed. Thank you, Dr. Selvamani. Thank you, Dr. Chetan Shah. Thank you. Bye.
Thank you
so much. Thank you so much, Raju sir. Just before we close, I know that we have already passed the time, but there are a few questions from the audience. The first question to Dr. Selvamani, sir, should a treatment intensification be based on absolute LDL-C levels or percentage LDL-C reduction?
See, actually, previously we were looking at the percentage reduction. We were recommending at least 50% reduction from the baseline. But today, apart from that, even the primary goal, whatever for that risk characteristic, whatever is important, we should reach that also. For example, if somebody had an LDL of 200 and then you put them on statin, you bring them to 100, that may not be sufficient. Or for example, if he's a high risk candidate, is LDL should be less than 70. Very high risk means less than 55. So you should aim the LDL reduction to the goal levels, not only the percentage, but probably percentage is also important, and then goal is also important. You can use both the combination, whichever is lower, try to attain that level.
Right, sir. There is one more question to Dr. Shah. Sir, should all ACS patients receive upfront combination therapy with high intensity statin and ezetimibe at discharge?
You are muted, sir.
Sir, you are on mute.
Yeah, Dr. Sandesh. So yes, preferably if we can give, then it's my practice to give all ACS patient upfront combination therapy of 40 milligram of rosuvastatin and ezetimibe at discharge.
Yes, sir.
Yes.
Yeah. Yeah. The question was, should all the patients...
Yes, I would say yes, that is my standard practice.
Right, sir. Yeah. So with this, as we already passed, our time is already 9:45. And so with this, although there are many questions, but considering the paucity of time, we'll not be able to take the rest of the questions. So with this, on behalf of Nexa Division of Intas Pharmaceuticals, I extend my heartfelt gratitude to all of you for being part of this wonderful, enriching session of Lipid Lectures by Lipitas. And thanks to our both esteemed speakers, first Dr. Salomoni for elaborating the key highlights from the ACC HD's lipidema guidelines, and for Dr. Shah for highlighting the role of combination therapy post ACS. A special word of thanks to Dr. Raju Karnik sir for steering the session and adding depth to the discussions. And to all our attendees, thank you so much for your time and engagement. And we hope that this platform will continue to support your clinical practice with meaningful science and expert collaboration.
Thank you.
With this, I wish you all of you a very pleasant evening and a very good night. Thank you so much. Thanks a lot.
Good night. Bye-bye.
Good night, sir.